I'd like to next introduce to the stage Dr. Dan Lee from Kaiser Permanente. He's a senior physician and a gastroenterologist at KP Northern California and a clinical investigator at KP's Northern California Division of Research. His research focuses on screening and prevention of stomach cancer in diverse U.S. populations. He's extensively well-published, and he also serves on parts of the guidelines committees of the American Gastroenterological Association and the American College of Gastroenterology. Dr. Lee.
Thank you, Robert, for the introduction. And I want to thank Jill Huang and Robert for inviting me to this really wonderful conference. It's really a great honor for me to be here. So my presentation is about gastric cancer prevention, the Kaiser Experience. At first glance, this may be a little hard or challenging to present because, as you know, in the U.S., in most institutions, including Kaiser, we don't really have a prospective screening program for gastric cancer. So it's a little challenge for me to talk about it. But on the second thought, over the years, we have accumulated a lot of data on H. pylori and gastric precancer lesions that may inform, in some way, the prospective strategy in the U.S. on gastric cancer prevention that I'm happy to share with you today. Just to talk about Kaiser briefly, our institution is a large integrated healthcare system. It's one of the largest in the nation, nonprofit healthcare systems. We have about 12.5 million members nationwide, and we're an integrated system, meaning that we combine the healthcare coverage and healthcare delivery into one healthcare experience for our patients. So that's our advantage, and we're a membership-based and prepaid healthcare system. So in terms of Kaiser Northern California, we're one of the largest branches in the Kaiser system, and we have about 4.6 million members in the recent data, and about close to 10,000 physicians in our region with 21 hospitals. It's really important to mention that our member population is very close in terms of demographic characteristics to the general population in Northern California. So this gives an advantage of conducting a population-based study that has, those studies can have really high or relatively high generalizability in terms of findings. So over the past 20 years, this slide showed you we have about from 250 to 400 patients with gastric cancer every year in our region. And with expanding member population, you can see we have closer to almost 400 cases a year over the past 3-4 years. And among those cancer patients, you can see that about 51% of patients are Caucasian, and 20% are Asians, and 17.6% Hispanic, and 10% are Black individuals. And we did this study about 10 years ago, and we showed that as it's very consistent with national data, we have a substantial racial and ethnic disparity in terms of gastric cancer incidence in our region. You can see that overall the trend is going down over the years, but the incidence rates of gastric cancer among Asian, Black, and Hispanic members in Kaiser are actually about 2 times higher compared to non-Hispanic white individuals. And in terms of the histology subtype, you can see that in our member population, about 5.4% of patients with cancer have immunoendocrine tumor, and 8% had GIST, and about 81% had this adenocarcinoma, which we all know that H. pylori is the most important risk factor for this group of cancers, and really highlighting the importance of primary prevention, as Dr. Meira has mentioned, to eradicate an H. pylori, to reduce the incidence of gastric cancer, specifically adenocarcinoma. So if you look at the literature, actually you'll find that the recent data on epidemiology of H. pylori in the US is actually very limited. So how common is the H. pylori in our communities? So we did this study over the past couple of years. We identified all people in our Kaiser's region who received their H. pylori testing over the past 20 years. And we divided the testing based on the testing methods, non-serology versus serology. Non-serology tests such as stool antigen test, urea breast test, gastric biopsies, they can tell you the active infection if it's positive. But the serology can be misleading because you cannot really differentiate between the active infection versus prior infection. So we found that using non-serology testing method, we found this is the burden of current the active infection of H. pylori in our member population over the past 20 years. You can see the overall burden is going down substantially. But you can see that over the past decade, the infection rate has been pretty steady, even slightly increased in our member population. This could be because of cohort phenomenon, also could be because of the changing demographics in our member population over the past decade. So to kind of like stratify based on the demographic categories, you can see that overall our member population had an average positive rates of 18.2% among all members. And but there's quite substantial racial and ethnic differences here. You can see that among Asians, about 23%, Black 25%, and Hispanic 28%. For non-Hispanic white members, about only 10%. There's quite difference in terms of the rate of infection in our current member population. And you can see that the rate of infection slightly increased over with increasing age in our member population, and also it's more common to have men than women being infected with H. pylori. But there's one thing to emphasize here is that for our member population Kaiser who speak non-English as preferred language, they have about 2 times higher rate of infection compared to people who speak English as preferred language. So this information really help us to design strategy to prioritize the target screening for H. pylori in our member population. And next question is that, what's the impact of H. pylori treatment on the risk of gastric cancer? We know that we have a lot of data from East Asia, and as Dr. Meira nicely summarized, and based on the randomized control trials, if you screen and treat H. pylori, you can really decrease the risk of gastric cancer, primarily based on Asian studies. But in Kaiser, we don't really have that an advantage of any large trials. So we did the retrospective study. It's a cohort analysis. We identified all people who were tested for H. pylori over the 18-year period from 1997 to 2015. And then for those who test positive, we separate based on the non-serology versus serology. And then among the positive individuals, we divide based on the treated versus untreated groups. And then we follow the patients through the end of 2020 to measure the incidence of non-cardiac gastric adenocarcinoma in those patients. So here's the key finding here. You can see that the patients who test negative for H. pylori has lowest risk over the 20-year follow-up. And those who had positive H. pylori testing but treated had a higher risk. But those who had test positive but untreated, you can see that the risk is really the highest. And you can see these 2 curves, the top 2 curves started to separate after 8 years after treatment, which is quite interesting. And so overall, when we did the proportional hazard method analysis, you can see that we used the H. pylori positive individuals untreated as a reference group. We found that for those who test positive but treated, over the first 8 years, we didn't really see much difference between treated versus untreated. But after 8 years, we found a quite significant reduction, approximately 63% reduction of incident gastric cancer at 8 years or after 8 years after the treatment of H. pylori. And we also did the measurement regarding the relative risk of non-cardiac gastric cancer compared to our member population, which is considered like background risk in our general population. And as shown, it's just like this yellow orange bar here. You can see that after treatment of H. pylori, the first year after treatment, the risk among tested and treated individuals is about 2-fold higher. But over the years, it started to decline to a 50% lower risk compared to general population after 10 years treatment, which is quite substantial. I want to bring your attention back to this curve again, because you can see that among those people who got treated, the risk is still pretty high. And you measure the risk, you found that actually among those who got positive test and treated for H. pylori, the risk of gastric cancer is still like 2.7-fold higher compared to the H. pylori negative individuals. Why does this happen? One reason that we didn't really measure we didn't really confirm eradication for all patients got treated in our population. That could be a part of it, but that's not the main reason. I think that our success rate about 80 to 90%, so it's decent. So I think one important reason is that behind this is because a lot of people with H. pylori infection already harbored pre-cancer changes such as IM or dysplasia that can basically progress despite the treatment of H. pylori. That really highlights the importance of secondary prevention of gastric cancer using the effective endoscopy for screening and treatment. So about 8 years ago, we published this retrospective cohort study in our region. So we actually identified all members with endoscopy in between 1997 and 2006, and with biopsies. So at that time, we didn't have any fancy tools. We didn't have like machine learning or NLP, and so we did like a manual review of 13,000 pathology reports, just to make sure that they're like confirmed gastrointestinal metaplasia or dysplasia, and we removed all people with cancer on the endoscopy. So we exclude all people who had prevalent gastric cancer just to measure the instant gastric cancer risk. So just because of time, I'm just going to show that one key finding is that for those who had intestinal metaplasia, compared to our member population, they had about 2.56-fold higher risk of gastric cancer, instant gastric cancer, and then. There's a little glitch on the slide. So for those who had local dysplasia, they had about 25.6-fold higher risk of developing gastric cancer during a follow-up. And I also want to highlight one study from my colleague, Dr. Buxian Wu from Kaiser Southern California, who published a different study about the same time as we published our paper in 2016. So Dr. Wu did a combined cohort and case control study. And the key findings here, so basically for those who had a family history of gastric cancer, those people had like 3.8-fold higher risk of gastric cancer compared to with no family history. And for those who had extensive GIM, the risk is about 9.4-fold higher risk, which is very substantial. So these data, although not really RCTs, but they still provide some guidance to help us for risk stratification and also for to guide us for designing strategies for secondary prevention of gastric cancer. So I'm going to talk about the gaps and challenges. I think this really should be the focus of our discussion in the summit, because this is how we can improve our practice on gastric cancer prevention. So in terms of primary prevention, I think we don't really have any data regarding the testing results of asymptomatic individuals. So all the results I'm showing you are those who got symptoms, got tested. But in the US and in Kaiser, we don't really have any data in terms of feasibility and outcome of screening people who are asymptomatic for their H. pylori status, and also what happened after you're screening for H. pylori. This is actually something we should do in the near future. And also, we don't really have any local regional H. pylori antibiotic susceptibility data, which is basically a limitation for us to choose the effective antibiotic for those for H. pylori treatment. That's why I don't really have a very high level of success rate, only like 90% or lower, to eradicate H. pylori in our population. Regarding the secondary prevention, and we don't really have any prospective data. This is a huge limitation in the U.S. Regarding the benefits of annual screening for gastric cancer, and also there is a huge gap in our quality of endoscopy, because as I mentioned, as mentioned by several speakers before me, that we don't really do a good job on endoscopy, and a very quick endoscopy in general, and with no cleaning, with no MBI. How can you find GIM without a careful evaluation? That's a huge gap in our practice, and also I think in general in the US. And the next one is the lack of precision in our ability to risk stratify patients. So for example, we try to talk to our pathologists about subtyping of GIM into complete versus incomplete. And what I got from them, that Kaiser, we actually, all pathologists reads the gastric biopsy results. So we do have a core group of excellent GI pathologists, but GIM is read by all pathologists. So the quality cannot be controlled, cannot be guaranteed if they do subtyping of GIM in our whole member population. So it's not really feasible to do at this point. And also, we don't have OGA or ORGIM, which have been validated in many studies in the world, but not available in the US for us to risk stratify our patients. One thing as I think is basically interesting I want to talk about is, for example, oftentimes you see small spots in the antrum, that's actually GIM. If you see one spot of GIM, you know, oh, that's probably very low risk. No H. pylori, and you don't have to bring patient back. But what if you see like 2-3 spots or 5 spots of GIM in the antrum? Do we bring them back or not? It's unclear. So I think even the current guidelines from Europe or from the US, we don't really have this evidence to guide us. I think the European guidelines suggest that if you have antrum GIM, low risk, don't bring them back. But in our own practice, we found a lot of Asian patients, for example, they have quite extensive GIM only in the antrum. I believe they have higher risk, but that needs to be studied and proven to be the case. So in summary, at KP Northern California, H. pylori burden decreased over the past 2 decades, but the rates of active infection remained steady over the past 10 years. And among the test individuals, 1 in 10 non-Hispanic white individuals, 1 in 4 Asian, Black, or Hispanic individuals, and 1 in 3 individuals with non-English language preference had active H. pylori infection. So these findings may inform our strategy to perform targeted screening and eradication for H. pylori among high-risk population in the U.S. And also, the H. pylori treatment has significantly reduced risk of non-cardiac gastric cancer, suggesting a great potential for gastric cancer prevention through population-level H. pylori screening and eradication in the U.S. populations. And lastly, our KP observational study demonstrated the increased risk of gastric cancer in patients with IM, dysplasia, and with a family history of gastric cancer, supporting the secondary prevention of gastric cancer through effective endoscopic screening and surveillance. I want to thank Dr. Corley and the TPMG DARE program for their support. And I want to thank Dr. Fox, our Chair of Chiefs GI, and our regional leadership at Kaiser for their strong support on our projects, and also our wonderful analysts, Sophie and Sophie, for their great work. Thank you very much.